Hello guys, today we will talk about frequently dislocations, and today it will be a dislocation of the collarbone. But you need to understand that it is not a collarbone, yeah, it is a clavicle. Yeah, great. And in good idea, let's get it started. Yeah, let's go. Dislocation of collarbone. You remembering that I say that all dislocation have indirect mechanism of injury. Yes, and dislocation of collarbone too. Sorry. They need to understand that dislocation of the clavicle account for 3–5% of all dislocations. It's not often, but sometimes we have it. More often we have damage, yeah, or fracture of collarbone, of clavicle. They arise mainly as a result of an indirect mechanism of injury, a fall on the upper arm or a withdrawn arm, a sharp compression of the upper arms along the frontal plane. And there you see two pictures how people can get a dislocation of clavicle. There were a dislocation of the acromial and sternal ends of the clavicle, and the first occur 5 times more often. Of course, in the pictures you see there we have a dislocation of sternal end of clavicle, and there we see a dislocation of acromial end of the clavicle. Now we will talk just about dislocation of the acromial end of clavicle, and we start with clinic. Yeah, I don't translate name of slide, but I think that you understand that it is a clinical picture, yeah, or clinic and diagnostic of patients with this trauma. A characteristic mechanism of trauma in the anamnesis, yeah. Like always, first of all, we ask for patient what happened with you, and he say I fall on my arm, for example. Yeah. Complaints of pain in the acromial joint area, moderately restricting movement in the shoulder joint. At the site of the injury, swelling and deformation are noted, the severity of which depends on the presence of a complete or incomplete dislocation. With complete dislocation, the acromial end will stand up significantly. You can feel its outer surface under the skin, like there. And when moving the shoulder blade, the clavicle remains stationary. For example, the movement of shoulder, yeah, the clavicle don't go away. With incomplete dislocations, the clavicle retains a connection with the scapula through the back clavicular ligament and moves together with the scapula. We please patient do some movement of shoulder, yeah, and we see that clavicle will go with shoulder, yeah, like a dance, for example. Yeah. This is incomplete dislocation. Palpation is painful in all cases. When pressing on the collarbone, dislocation is quite easy to eliminate. but it is worth stopping the pressure. It occurs again, and this is interesting sign, and it calling K symptom, which serves as a reliable sign of rupture of the acromial clavicular joint. X-ray. X-ray examination facilitates the diagnosis. When reading radiographs, one should pay attention not so much to the width of the articular gap. Its magnitude is variable, especially with incorrect wedge, as to the position of the lower edge of the clavicle and the acromial process. If they are on the same level, then the ligamentous apparatus is intact and there is no dislocation. And if the clavicle has shifted upwards, then the boundaries of the levels change. Okay, there you see two pictures with two X-ray films with clavicle dislocation, but they are not right, yeah, because we don't see a normal. We don't see a normal clavicle. There are conservative and operative methods of treatment. You see this type of treatments. The reduction of the dislocated acromial and of the clavicle is not difficult, but it is quite difficult to keep it in the right position by conservative methods. For fixation, a variety of bandage, splints and devices are used, supplemented with a pellet pressing on the acromial joint. And for example, you see there that we have something like horseshoes, yeah, what will press to the clavicle, yeah. And you see that we use Deso bandage and soft Deso bandage and sometimes a clap. The period of immobilization with all conservative methods is 4-6 weeks. Subsequent rehabilitation treatment allows you to restore your ability to work after 6 or 8 weeks. The effectiveness of such treatment is 50%. In case of failure of conservative treatment and long-standing dislocation, patients should be sent to a hospital for surgical treatment. The creation of acromioclavicular and clavicular ligaments from outer tissues. Elements of synthetic materials: silk, nylon, Dacron. And now we will talk about dislocation of acromial and of the clavicle. Etiology. Dislocation of the sternal and of the clavicle occurs as a result of an indirect mechanism of injury, excessive deviation of the shoulder and upper arm posteriorly or anteriorly. There you see how these people do movement of arm, yeah, and with rotation, yeah, and when he does this rotation, clavicle go way down, yeah, and if he do this rotation, clavicle go way there. Take some pushed, yeah, some hit, and you will have the dislocation. I'm worried about pain in the sternoclavicular joint. In the upper part of the sternum, a protrusion is determined, which shifts with the reduction and dilution of the upper arms and deep breathing. The tissues are edematous, painful on palpations. The upper arm on the side of the injury is shortened. Oh, sorry, there is a few words what I don't translate. I'm so sorry, guys. To confirm the diagnosis, radiography of both sternoclavicular joints in a strictly symmetrical arrangement is necessary. In case of dislocation, the sternal end of the clavicle shifts upwards and towards the midline of the trunk. Its shadow overlaps the shadow of the vertebrae and is projected high compared to the healthy side. And there you see right X-rays in right side, where we see that one clavicle will be upper than left. Treatment. The best anatomical and functional results are achieved with surgical treatment of this injury. The operation is performed according to the method of the Marxer. The collarbone is fixed to the sternum with a U-shaped. No, it is. I don't know how I can say it in English because you haven't got this word. But I think that it is U-shaped. Yeah, this is U-shaped. Yeah, you're right. U-shaped form of suture. U-shaped transosseous suture. Divergent splint or thoracobrachial plaster cast is applied for 3-4 weeks. Recovery of working capacity is possible after 6 weeks. That's all, guys. Thank you very much for your attention, and we will see in next lection about dislocation of the upper limb. Be healthy, don't have any trauma, and don't worry, all will be better than today.